And we're at 5 o'clock. So welcome everyone to CalCare Office Hours. We're here to talk to you about everything that is AB 1400 and answer questions, hear your stories, talk to you directly. And I want to wish you a happy good evening. Happy January 23rd of 2022, which I thought was 2021, which seems to be a replay of 2020. Anyway, happy Sunday to you. So, CalCare Office Hours. First off, I actually do want to give a birthday shout out to our fearless leader and carrier of AB 1400. He decided to take AB 1400 and carry it through the assembly. Assembly member Ash Kalra just celebrated his birthday this past week. So we want to give him a very happy birthday and a very sincere thank you. I owe you vegan cupcakes. I promise when you're back in LA, we will make sure you get nice vegan cupcakes. So I want to make sure that we give you happy birthday to you. Sorry, had to break that down a little bit. Break it down. So, you know, because it's very important that we celebrate everyone's birthday. I mean, just being around and thank you so much for taking AB 1400, knowing that this is what we need and seeing how much suffering is going on and being innovative and challenging that status quo. When you are alone or in a very small minority, as most of us on this Zoom know, and probably in Facebook land, because we tend to be on the progressive side. If you're watching this, you tend to be probably left leaning, unless you're spying on us. And if you're spying on us, fantastic. I hope you learned something. But, you know, when you're challenging that status quo and you're in a minority and you're putting yourself out there on that line and as a sole voice, sometimes when you, even though you have people behind you, you may be the only one that can take the microphone at once. That takes real big courage. And so Assembly Member Aj Kalra stepped up and carried this bill, and that took a lot of courage. So I hope you had a fantastic birthday. I looked like via Facebook you were doing all the relaxing things. So great, because I know you're getting ready to really battle on that assembly floor. So we just want, on behalf of Healthcare for All Los Angeles, want to give our sincerest, happiest birthday to you. Once again, when you're in LA, we'll have vegan cupcakes for you. So happy birthday, Ash Kalra. And then moving on, big news, big news, bigly news. Huge news is that we passed the appropriations. And the reason why I'm laughing is because on Thursday, my palms were sweaty, my feet were sweaty, I was sweaty. And I didn't even know that we were able to actually give comments, because we were told that appropriations in suspense was a closed meeting. And so I decided to keep working, thinking that we weren't going to be on. And then I saw the Facebook post, and I literally had a like, holy crap, like in the middle of the hospital, like, ah! You know, and they're probably going to admit me to the psych unit. But, you know, I was just like, we passed appropriations. I was so excited. This was a big hurdle because we were not certain. Like, if you watched last week and we had Ryan Skolnick from CNA with us, none of us were certain what was going to happen with appropriations. We all had very big hope, but we didn't know where everyone sat on it. We know we had a few people on our side that were certain yes votes, but we didn't even know for certain if the chair was going to go. And it looked like, I think it was a party line vote. Like, Democrats voted yes, the 3 Republicans voted no. Not correct who was there, though. I think it was party line. So it was a party line vote, which I was actually surprised, I won't lie, because this bill is not, you know, even there are Democrats that are not in support of it or who have expressed their uncertainty about it. So I was very surprised to see that it did go a party line, which meant that the Democrats voted yes, like I said, and Republicans voted no. So this is huge news. So now we're going to the assembly floor, which will be happening either on or before January 31st. And it could be happening as early as Thursday. So we're going to the floor, and so we need 41 votes to get passed. It's like 50 plus 1, and there's 80 assembly districts, so we need 41 votes. So with that being said, districts 1 through 80, we need people calling. If you live in districts 1 through 80, which you do because you live in one of them, please make sure you are calling your assembly member, even if they're on board. Like I said last week, if your assembly member is on board or they're a co-author or sponsor, you don't have to call them to ask them to vote. Yes, just call them and say, hey, you know what? Thank you. You're the real MVP here. And then call your friends and tell them that we're calling you to say thank you so that they can get calls to say thank you. So, you know, for example, District 79, Dr. Akilah Weber, Shirley Weber's daughter, she abstained in the appropriations. And as a Black woman, I'm kind of wondering why the Black doctor abstained the vote. I'm not in her district. I'm not being aggressive here. I am curious. I'm curious on the rationale. When you approach things, when you're talking to these assembly people, and if you've been around with me and the OGs through 2016 and all that stuff, we've done enough yelling for probably 2 lifetimes. And we will still yell if need be. Don't get me wrong. Maureen is like smiling because she's like, oh, you're so young. But she's like, I'll still yell. And so, you know, we will still yell, but right now we need every vote. So if you're an AD 79, it would be interesting. Come back, report back. If you talk to Dr. Akilah Weber, what was the reason for the abstention? You have a right to know. It's not questioning her. It's just saying, hey, I'm one of your constituents. I really support this bill. I think it would be great for the people in our district. I wanted to know what made you abstain the vote. And then have her staff like explain. I'm not going to go into my brain, which is telling me what physicians association is behind you, but I'm not going to go there. I'm just going to come from a point of curiosity and a point of open rationalness, because we still need that vote on the floor. So AD 79, that's one of them. I'm curious. And yes, thank you, Betty. I think she does need to see power to heal, because the Medical Association, the American Medical Association, was back then historically racist. And that's what created the National Medical Association, because basically the Black physicians and physicians of color were basically fed up with it. All facts, please watch Power to Heal. It seems like we almost have screenings yearly. It seems like it's becoming, I think that's going to be a HCA tradition, is probably to have a screening of Power to Heal yearly. I kind of committed us to now that, Maureen, I'm sorry. All right, so let's get right into it. So I've been talking a lot about this bill, celebrating us passing, the Appropriations Committee, but then if you're new to, if this is your first time coming or joining us in the Zoom room, what is AB 1400 and why am I seeing so many posts about it? And why are there so many backgrounds that say, do you CalCare? Well, let's talk about that. So CalCare is a California Guaranteed Health Care for All Act. It is a bill called AB 1400, Assembly Bill 1400. And it is a very comprehensive Jeanna approved bill that was brought forth and helped created by the California Nurses Association. And as you heard me earlier, is being carried by Assembly Member Ash Kalra through the Assembly, and now a lot more co-authors and sponsors. But it is the Guaranteed Health Care for All Act. It is basically a solution to our broken healthcare system. Now, I've heard in these committee hearings, both sides, whether they oppose or agree AB 1400, have said that the healthcare system needs to be fixed. Now, so that's big, that everybody actually agrees on this one thing. We do have a broken healthcare system. I don't think anybody is disputing that. But this will guarantee healthcare as a human right in the state of California, providing comprehensive, high quality healthcare for all, just like Medicare for all will do nationally. We're providing universal coverage. So we're saying everybody in, nobody out. And that's regardless of your race, sex, gender, your country of origin, disability status, immigration status, marital status, age, income, all of that happiness. You get the care that you need, regardless of your ability to pay. I know that sounds really, really like pipe dream. I need a magical genie, but actually you'd be surprised how many countries actually have this. That aren't as rich as us. So we're talking about a single public program. Single payer is publicly funded through progressive taxation. I know taxes. I said the taxation word. I can't make it any prettier, but we're going to be the bull and ram that taxation word right just where it is. We're not going to run from the word taxes. We are going to talk about taxes. We're going to continue to give you talking points to go back and to people who freak out when they hear the word taxes. I understand why people are freaking out when they hear the word taxes, but progressive taxation means The little less income you make, the less you get taxed. The higher income you make, you might get taxed a little more. It's the progressive side of it. So to cover all necessary care in California, and I will add, this also is in addition to, we will get funding from the federal for the Medicare and our federal funding from the waiver program. So that's why the taxes actually we are going to fully fund AB 1400 just with taxes, just putting that out there. But we are going to eliminate billions in bloat and waste and save you, the person, the sick, the ill person, the patient, the Californian, thousands of dollars on your healthcare costs, because we're taking away your copays, your deductibles, your medication copays, taking all that away. So you will save money. We're going to give you fully comprehensive benefits, more than probably what you get now. This includes medical, dental, hearing, vision, mental health, prescription drugs, long-term care, and more. All decisions about healthcare would be made between you, your doctors and nurses, not the insurance companies. You're going to have freedom to choose your provider. So under CalCare, there will be no more in-network or out-of-network. And you will have the freedom to choose any doctor or hospital you like. Now, I will give a caveat, because Jeanna's going to keep it 100, keep it very, very real. They will have to be in CalCare. So when CalCare rolls out, they will have an opportunity to opt out. It will be stupid. It will be like opting out of Medicare, which you wouldn't want to do, but they do have an opportunity. So if, for example, that provider decides to act like an anti-vaxxer and just opts out of CalCare, then maybe you won't be able to go to that particular provider because they decided to opt out. I guarantee you, after the 2-year period, they will be begging the first application when it opens up to get into CalCare, because they're going to see their bottom line hurt from being outside the CalCare world. So that's just being honest. But at the same time, it's like I said, opting out of CalCare will be very similar to opting out of Medicare. No provider is opting out of Medicare. And then, so we're talking free at the point of service. Like I said, no more co-pays, premiums, deductibles. That puts money back in your pocket. You're going to arrive at your doctor's office. You're going to go in and they're going to be like, oh, good morning, Ms. Harris. How are you? Blah, blah, blah. Cordial greetings. And then I'm going to be like, oh, I'm good. I'm here for my 9 o'clock appointment. And then I'm going to show them my little CalCare card, and hopefully it's pretty. Talk to Jeanna for the design on the card, guys. And I give them my little CalCare card, boom. Or maybe it'll be even in my Apple Wallet, because I have my vaccination stuff in my Apple Wallet. So maybe it's in my Apple Wallet, because that's where my other stuff is. And I just sit there and go boop. And then they're like, okay, have a seat. You may have to still fill out the forms. So sorry, you still may have to fill out those, what medications are you still taking and all that stuff forms. Some of those forms go away, but nonetheless, it'll still be free at the point of service. We're not going to ask you for money. Just transition. So I used to work in that part of the industry that did managed care. And I know the faces that this will affect. I know these people, these are my friends. So when I'm talking about eliminating some of the stuff, I know I'm going to be directly affecting people. I know their names, I know their family. So it is very personal to me that we take and look after people who will be affected by this in the insurance industries. And I don't care about the CEOs. They'll just bankrupt, take a big bonus and roll somewhere else, or slither somewhere else like they're snakes. But I'm more so concerned about my friends who are just providing for their family. But the thing is, a lot of the roles that they do, somebody still has to enter claims. There will still be claims that have to be processed. We can take them and we can use them in the CalCare world. I don't care about their CEOs. I care about that individual worker, and so does CNA, because CNA is a union. We're about labor over here. And so we're going to provide a just transition funding programs to protect and support displaced workers in the insurance industry. After AB 1400 passes, then that will be built out a little bit more so that people will understand what that just transition is going to look like. And then we're going to do patient care based on patient need. No more financial incentives to avoid providing the necessary care. No more creating these narrow networks of very low cost providers just because it doesn't cost much. We're going to make sure you get the quality care without having to worry about, oh, well, we want to send them to this provider because the rate's cheaper there than here. That's still financial incentive. No, the pharmaceutical companies aren't necessarily paying out or bribing doctors like they did in the heyday, but there's still financial incentives that are being done to basically increase the bottom line. Why? Because we're treating healthcare more of a a commodity, like a product, then we are treating it as care. Like as, oh, well, if we keep Californians healthy, that means they keep working. That keeps the GDP going. That keeps everything going. Instead, we treat the healthcare like a commodity, like a product. And that is the problem. And when it's monetized like it is, and it's considered a commodity, they worry about profit margins. It's ran like a private company. Then you see these financial incentive and profit margin strategies like a private company. This is not a private company. This is healthcare. It was never meant to be privatized, but it happened. So no more financial incentives to avoid providing necessary care. And that is your CalCare basic principles. Yay, stop sharing. All right, so I see from Facebook, from Lynette. Hi, I just received my Medicare package through Kaiser Advantage, and the copays have been deleted for 2022. Just wanted to let you know so you could look into adjusting your language if needed. However, can you address the $171 monthly premium to Medicare? Sure. If that is going to be eliminated, that would be a big selling point. I'm so excited and hope that this goes forward and passes. I worked for 15 years in group health field and know the system know the profit and waste in our system. Lynette, if Kaiser, I haven't looked at the Kaiser 2022 benefit package. Actually, thank you for putting it on my mind. I probably should. If they're eliminating their copays, fantastic. But you're still stuck within Kaiser. You're stuck within that Kaiser network. So, and people, I mean, granted, people love, people hate, you know, Kaiser. It's its own conglomerate. So, you know, if that particular product you have with Kaiser under the Medicare Advantage, which is the Part C of Medicare, you know, if they have eliminated their copays, great, but I also want to know what they are doing to make sure that profit margin continues to grow. Everything is a give and a take. So if they took that copay, well, how narrow is that network? Is it open to all of Kaiser? Or are you still open to all of Kaiser? Or are you even more restricted? So you have Kaiser, which is like restricted, but now that if you chose this plan that eliminates copays, which is a fantastic selling point, I know so many seniors who will just definitely be like, and that's my plan, because they, you know, already are living on a limited budget. So that would be I would just look at your network. Make sure any providers that you are attached to now will continue to be in that network. Because like you said, if you've known this world, you know it's sneaky. So anybody who's choosing Part C or Medicare Advantage with a health plan, and all the health plans are in this, okay? So your United, your Anthems, your Blue Shields, your Aetnas, your Humanas, all of these, the big ones are in Medicare Advantage. They, like I said, they got their little grubby fingers on government money, but you are on their network. So if you have your primary care doctor that you've been seeing for 20 years, and you choose a Medicare Advantage plan for 2022, just make sure that your primary care doctor will still continue to be able to see you. Usually can do that by just calling their front office. They would probably know, saying, hey, you know what, I'm thinking of signing up with Medicare Advantage, Humana or Aetna plan, whatever. Does Dr. So-and-so take that? And if so, great. And like I said, I understand the cost. It's cost control at this point. Everything is cost driven for us as consumers. Which is the bottom line is sometimes we have to sacrifice our care just to be able to afford it. And that's why I'm doing what I do now, because to me, that's complete BS. So, you know, but like I said, if they did that, I'll look into it. But so then going into the $171 premium, which is actually increased from 2022, or excuse me, from 2021, that is, Medicare is not free as it stands today. I know that we've been pushing for Medicare for all, but it's kind of like improved Medicare for all on the national level. But as it stands today, Medicare itself, A and B, which is the original Medicare, that should have been improved upon decades ago when Jeanna was flipping pigeon mode and running through the streets or on her tricycle. That's when Medicare should have been improved upon, but it wasn't. So they keep increasing these premiums for the Part B benefits. Oh, and then not to mention, you've got to get another prescription Part D buy-up, and good luck with that one. So you're paying $171 minimum, And then you also are probably paying for your Part D coverage for prescriptions. And so you're paying hundreds of dollars out of pocket because Medicare is not free. That's why Part C, which is what Lynette had mentioned, the Kaiser Advantage plan, people hop to that plan because it's like more all-inclusive, but now you're in that plan's network. You're at the mercy of that health plan for whatever they choose to do. If they choose to contract with your doctor 1 year and your doctor is tired of their claims processing and not getting paid on time, so your doctor pulls out the network the next year, that just, you can't move. You can't just sit there and like, oh, I'm just going to go follow my doctor. You have to disenroll yourself. Then you go back to having to pay. And like I said, right now, for our seniors, are very cost and budget focused. So they will have to make that decision. Can I afford to pay for the original Medicare, or do I have to stay here and just lose that relationship I had with my doctor? Happens every single day. I talk patients through it every single day, at least one patient a day. I kid you not. I have to have this conversation with them. All right, Maureen, I see you put your hand up.
Yes, I just wanted to mention about the Kaiser. I mean, unfortunately, I have Kaiser Advantage as well, and I would have gotten out of it this year if I had any time. I had been a Kaiser patient since I was 10 years old, 1960. And I will say that the Kaiser started being problematic in the mid-90s for a lot of people. Kaiser is being sued by the federal government, by Medicare, actually, the Centers for Medicare and Medicaid Services. They're being sued for fraud, for billions of dollars, for billing for billions of dollars that they shouldn't have billed for. They're also being sued on a separate level by some municipalities, one of them being San Diego. I don't remember if it's a city or the county, for providing a fraudulent provider list, which is why now, if you call and say, I'd like to see my specific provider, for some people are told, I mean, because there are different plans, but some people are told, like my daughter, for instance, oh, if you want to see your gynecologist, well, that'll be 10, 12 weeks. If you want to see someone else, it'll be a month, for a problem. And then if you have a real problem, go to urgent care, So Kaiser is being sued. In terms of their providers list, they have listed, the lawsuit says that they've listed 35% of their listed providers and services do not actually exist in Kaiser, which is why you wait a long time. I've also noticed, there's a law that says they have to get back to you within 48 hours. Well, the way your provider gets back to you in 48 hours, that someone from the office calls you and says, hey, we got your inquiry, and we see it, and we'll get it to your provider, and we'll get back to you.
Oh yeah, well that helps.
That's fulfilling the 48 hours, okay, of your provider will get back to you. So there's a lot of fraud. And another issue, the third issue, is this upcoding, which and by the way, Kaiser's not alone. A lot of these insurance,
all the upcoding happens across the board.
Yeah, across the board. So if you want to move like from Advantage, an Advantage program, and you want to go into regular Medicare, you need to also get a Medigap plan, which if you had AB1400, we wouldn't have any of this. You wouldn't be messing with any of this. You would never see a bill. So getting a Medigap plan, they look at your record. And if you've been upcoded to make look like you're much more of a risk than you really are, you may be denied a Medigap plan based on false information or exaggerated information. So that's a problem too. I mean, do we want a healthcare system where honesty is there? I mean, shouldn't there be an honest assessment of your health? Not a fraudulent assessment of your health. So this is a real problem. Whenever we leave money in the system, that's the problem. They will find a way to make the money.
Well, it goes back to being profit driven. When you are privatized, privatized, your goal, you're not answering to the people. Okay. Like I would get so tired. I would be on calls with VPs, and I would be on calls with people high up, and they would be giving like all these, which is supposed to be an inspiring conversation for the employees. And they would be talking about stakeholders, and they would be talking about leadership. And I didn't hear as much talked about the patient, the person, stakeholders. That's flipping Wall Street, you know, like I don't own stake in it. Well, did I? No, I didn't own stake in that company. So I'm not a stakeholder. I'm an employee, which yes, you could call me a stakeholder, but I prefer to be called a teammate. I prefer to be called a Jeanna because that's what I am, a Jeanna. And I prefer my patients to be called a patient, not a member, not a customer. I want you to be called a patient because when I say my patient, that puts my brain, okay, you need my care. You need my love, my compassion, my happiness, but when you're my customer, okay, I'm supposed to just, oh, you're a customer, transaction done by. When you're a member, okay, you're a member of a private club. Oh, you're so exclusive. Welcome to the Bezos world. No. So you're my patient. And as my patient, I care. But when you're talking about stakeholders, so when you have a privatized market-driven insurance company, which most of the private ones are, they're listed and you can go and buy stock in these companies, United Healthcare, Aetna, Humana, go find their stock numbers. Then they become profit-driven. They're worried about answering to their stakeholders. And they say that the member is a stakeholder, but you're not. They're talking about the board of directors. And so when you have to answer to that, where does it the fact that you care? Where do you care about my patient? Where do you care if they get the care that they need? If I'm telling you that care is going to be a little bit more expensive than maybe you thought, where does that happen? It doesn't. So when you're publicly driven, you answer to the people, public, me. I am the public. This is my money. This is my system. So this is why AB 1400 is the people system. This is your healthcare system. So as much as, Ash Kalra and the sponsors and co-authors are carrying this bill, this is our bill. This is our system. And we must take care of it as well for it to live and thrive. But at the same time, the people, the stakeholders the people that have to answer would be that now the government will have to answer to us and not a private profit-driven organization. Granted, we need to make sure this is sustainable. But at the same time, we are not going to be worried about every quarter that our profit margins grew. I saw companies' profit margins come down $60-something billion in 2020 during a global pandemic. The acquisition that brought me into that company was the driver of that big profit margin. Celebrations, yay! But guess what? I only got a 1% raise, and so I had to leave. Anyway. Going on to Christian Misu, she asked if a homeless person without proof of residency were to go see a doctor, would he or she have problems getting seen? Now, CalCare is going to have a homeless contingency. They're going to work to try to get the homeless patients enrolled into CalCare, but you would need to have some type of proof. But here's the thing, even currently as is, if you come into the emergency room with an emergency, you're not going to get turned away. And I think that just like in the hospitals, we work to get patients enrolled under emergency Medi-Cal if they come in uninsured and they're injured, a traumatic injury, something like that. We try to get you emergency Medi-Cal as fast as possible, or Medi-Cal pending. I think if I am to apply it and to kind of, speculate, which the whole America is built on speculation. So if I'm to speculate, basically, what would happen would be, okay, this person isn't in the CalCare system. Are they a California resident? Can they, even if it's as much as like, okay, where have you been staying? Oh, I've been staying at Venice Beach on Pacific and, Washington Boulevard, whatever. How long have you been there? Oh, well, I've been there, I've been in that area probably for the last 2 years. Based on that information, that lets me know you're a California resident. And so, or sometimes they get their mail sent to certain places. So they have a family member or a friend or even a church. This goes kind of in how we do voter registration. Some people, they get their mail sent to a church that they go to frequently. And by that, we can say they have established residency. So hopefully what will happen is that we'll build that into the hospital system as well, so that when what we call now financial counselors go to see a patient, that maybe they could just get them enrolled under emergency CalCare pending final verification. That's how we see it with Medi-Cal. So I'm hoping that will be a very similar system. So our houseless neighbors will still be, taken care of regardless of whether or not they can prove residency at that exact moment. But they do have they are going to work on how to roll out to the homeless as well. Okay, so thank you, Chris, for that question. And then just going through any other questions. Oh,
Randy Hicks has
oh
something.
yeah, about status of Ro Khanna's bill. I don't have that myself. Anybody know what's going on with the Ro Khanna?
You don't need it for AB 1400.
No,
That's the bottom line.
that's
with that.
well, yeah, because Ro Khanna's at the federal level.
Yeah.
So
I mean, I know that he wants to say it gives us permission and everything, but the fact is that it's an unneeded. It's really unneeded for AB 1400.
right, and
the ACA 11.
Yeah, and Assembly Member Carra verified that he actually went to DC because that was a big talk back and forth. Does the waiver? Do we have to have the funding, or necessary for do we have to have that bill for us to be able to apply for the waivers? And the overall answer, the final answer coming from the or the Health and Human Services (HHS), no. We do not. We need to have this policy bill, and which we have the bill, and then we can carry it to apply for the waivers. Betty, I saw you put your hand up. You want to comment on that as well?
Sorry. I wanted to actually go back to the Kaiser thing and the woman that was saying, okay, because I just wanted to, I realized I'd put something in the chat and not everybody could see that because we're live streaming. And thank you, Maureen, for letting me know that. But yeah, I just had recently someone ask me, and sometimes as a person that is it's always involved in single payer, they come to me for questions on healthcare, which I think is hysterical. It's like, and health insurance, but which is great, okay, because I kind of have some answers. I help them out as much as I can. But they asked me, they have Kaiser. And they went to a sleep study that Kaiser said to go to the sleep study, that she was having difficulties breathing and issues with sleeping. And they said, you need a CPAP. You need one of those CPAP machines. So when she went to go bring in, to get the CPAP machine from Kaiser, no, this is Kaiser telling her she needed the CPAP machine from their sleep study, saying she had a problem, because she did have a problem. And she goes in to do it, and they say, oh, your type of Kaiser with whatever coverage you have doesn't cover the CPAP machine. So yes, we recommended you have it. Yes, we believe that you have it. You need this. But sorry, we're not going to cover it, even though. So just want
that's strange, because if it's medically necessary, because usually it's the hoops to get through the CPAP. So you have to have a sleep study. And what I've done on the hospital side, and I think I'm snitching on myself, whatever, I don't care, I'm a rebel. Okay. What I've done on the hospital side is I'll have a patient that needs a CPAP that can't get to the sleep study because they have an HMO, and that sleep study is going to be booked out for a month. I know I'm going to see them back in the hospital before that month, and they have that sleep study. So truthfully, I'm saving my company money by doing this. But what I would do is that I would ask the respiratory therapists in the hospital to start them out on settings, and basically give me preliminary settings to push this authorization through. And then I would say, okay, now you got to promise me you're going to follow up with the pulmonologist to actually still get that sleep study done. But I got that patient what they needed. I created my own loophole to get the patient the care that they needed, the equipment that they needed. Because without a sleep study, and they only tell you that you need a sleep study mainly so they get the proper settings for the CPAP machine for you to have. But I could do that. I had the privilege, since I was in the hospital with respiratory therapy and all this equipment, to do that and get that kind of go around that loophole. But the only reason why I did it was because I knew the system would not move fast enough. It would be, to get that patient the equipment that they needed at the time that I needed them to have it. So, it's a mess, but for what she went through, if they had their order and had the sleep study and still was told, I would question that, because usually once you do that, there should not be a reason for denial. So I think that I would have appealed that. I think
she's going to appeal it. She's going to do whatever she can,
because it doesn't make sense. But once again, here we are. That's putting you back a month, maybe months, without her having that. And sleep apnea is very serious. It affects your health. And so, and her having to fight for a CPAP machine is it's asinine, especially when she went through the proper channels to get one. So once again, healthcare horror story. Thank you, Betty.
Thank you.
Okay, and then I just want to go just really quick. And then I'll go to you, Jeffrey. Oh, so Lynette just mentioned she had been with her doctor for 15 years and he is covered within the Medicare Advantage plan she chose, and responds to her emails within 24 hours. Nice. So yeah, lucky there, because some of them don't. They don't even know where to check their email. Anyway, Jeffrey, you want to ask a question, or you had something you wanted to mention?
Well, I'm going to offer one is the horror story, again, related to Kaiser, since we're on Kaiser, is that I have an individual that has an electric wheelchair here in Sacramento. And because that electric wheelchair costs more than $2,000, Kaiser is making him appeal, even though his electric wheelchair is not working, that he has to appeal and bring a lawsuit to get his electric wheelchair replaced, which will cost more than $10,000 to replace. Other thing I put in the chat was that the Rules Office has requested the Legislative Analysis Office to do a full study on AB 1400 again and the ACA 11. They're just going to be by March 25th. They're supposed to come back, and this is deference to the Republicans, so it's something more likely we're going to hear and see about in the Senate than we're going to hear about getting in. My concern next is getting through the Senate with AB 1400, and that's my comments.
Thank you, Jeffrey. I appreciate it. Electric wheelchairs, let me tell you, are so hard to get. I mean, just knowing from the utilization management side, the requirements to get an electric wheelchair, like some plans will make you go see a physiologist to basically make sure you're physically able to steer it, which I guess is proper. We need to make sure that you actually can steer an electric wheelchair and all that stuff for safety concerns. But to see a physiologist, do you know how long that takes? There are not that many out there to begin with. And to see a physiologist just to have an evaluation for a damn electric wheelchair. Yeah. So, we're affecting quality of life here. Someone who is in a wheelchair bound state and who cannot continuously propel themselves, quality of life is very important in those, and for people who are just wheelchair bound, period. And they already have an altered quality of life, just being wheelchair bound, just being a social stigma, disabled. But then on top of that, we limit them by the fact that they can only go where their wheelchair is allowed. And when you want to get out and go around and be, active in the community, you still can. I encourage it. When I have wheelchair bound patients, I always try to tell them that there's so much they can still do in the community. But then I also have to keep in mind that I need to check my own privilege, because getting around in a wheelchair, even though everything's supposed to be ADA compliant and all this stuff, it's not. Just getting in and out of a vehicle or getting on and off the bus can be very challenging in a self-propelled wheelchair. When you have an electric wheelchair, they're bigger, so now you have size constraints, but at least it gives you more mobility to get out and be part of society and things like that. So the rigmarole we put people through for an electric wheelchair is tough. It's not hard to figure out if someone qualifies or not for an electric wheelchair. No, we can't just give you an electric wheelchair because you don't feel like walking long distances. We want you to keep yourself moving as long as possible. But if you really need one, the hoops you have to jump through to get one through insurance is insane. Okay, Maureen.
That story. This is a congressional staffer of Conyers who actually worked on writing HR 676, the federal bill that Jayapal's bill was written from. And he had also a CPAP machine and or device, and it broke. And because of the just in time, he could not get it repaired. First, you can't get it repaired. Secondly, he went in to get another one. They said, no, you're not due for another one. From his, I don't know, whatever office he was going to for that, whatever his insurance covered. They said, you're not due for another one for, 2 years or something. And he said, but it broke. And they said, well, I'm sorry, we can't give you one. We don't even have one because we have to order them. So it's this idea that, care delayed is care denied, but also care delayed makes money because it pushes off, providing you with what you need to another time. So it was really terrible, the story of this guy, what he went through. And he's a retired congressional staffer to John Conyers. And he said his care is crappy. Okay.
Yeah, I mean, if you think that's bad for a CPAP, try a front wheel walker. Medicare, as it is now, because I don't want people to deter from Medicare for all, but as it is now, Medicare, you know, the front wheel walkers, the little silver ones, very basic silver ones, Medicare will only provide one for every 5 years. Those suckers are built to last 6 months, especially for frequent use, especially if you weigh a little bit, you know, if you have to use it every day. Those suckers are not built to last 5 years. Even, I don't care what medical equipment company lied to whatever executive. And so every 5 years, I'm only able to get you one, right? And even if it's got stolen or lost, to get another one approved, you would literally have to provide a police report, literally, to show that it's done. And so if I tell you that little old lady in my room is telling me that, oh, I need a new walker because this one's broken or it doesn't stay locked or something like that, which is a safety concern, I have to send her through so many hoops. Most of the time, I just tell patients to go buy them on Amazon, you know, or I might just try to rob one from the hospital supply. But anyway, I'm just giving out all my little secrets. So, you know, but I would just usually tell patients on Amazon, I think they're like $40 or something like that, because it's not worth the fight to get one through Medicare again. But 5 years for a front wheel walker, something that's like $40, that is ridiculous. Like you said, care denied, or care, you know, delayed is care denied, but damn. So just go to the chat. Like I said, we're going to try to keep office hours to an hour, because we have exciting things happening tomorrow, which I'll talk about here in a minute. So, you know, from Randy Hicks, how do we save the small hospitals being taken? Are they automatically released from the chain who took them over? After AB 1400, that's a good question. So for example, HCA, which is a huge, malicious, vicious group that has, I think it's one of the largest healthcare groups. They own the most hospitals in the country or something like that. Anyway, they're vicious. Anybody who works under HCA, which is not healthcare for all, by the way, I forgot what HCA stands for. But anyway, they're vicious. So if they bought some hospitals in rural areas, if AB 1400 passes, I can't say necessarily it will immediately let that hospital free of that organization, unless that organization pulls out. And just leaves them to themselves, which then CalCare will provide, you know, funding and will come in and help the rural and underserved hospitals. But if HCA decides to stay in California and to continue to operate, that was a transaction that happened before CalCare. So I don't think we would have too much ability to go and rip that apart. And this is me once again speculating. This isn't written in AB 1400. But just thinking of how this thing would apply. But, you know, a lot of the rural hospitals, and like I said, companies, these big hospital groups and organizations are going to react to AB 1400, probably like a temper tantrum. So the same way that happens when you tell the 3-year-old that they can't have the candy in the grocery store and they make that scene, is going to be the way that some of these insurance companies, these big medical groups, hospital associations are going to react as well. They're going to make a scene. They're going to have a temper tantrum, and it is going to be up to us on how we handle it. We can either feed into that temper tantrum and make a bigger scene in the grocery store, or we can, you know, tell them like, okay, well, you're still not getting the candy, but you can go ahead and cry it out, have fun. I'm actually going to leave you here at the store. Bye. So, you know, that is what I can foresee happening with these big groups. But if it, like I said, they decide to hang on, they decide to make it work, then I think some of the small rural hospitals will stay up under that umbrella. But, you know, like I said, there's a lot of rural hospitals that are not under that umbrella. Your small little community places that need care. Like I keep bringing up Bodfish, California, which is near like 30 miles outside of Bakersfield and Lake Isabella, because I see patients coming to UCLA for higher level of care come from these areas, and they don't have doctors there. I mean, it's such a small town, so rural, you know, I can't get them care up there for nothing. I can't find home health. I can't do anything, you know, it's an act of God, really, because it's so remote. But, you know, that means that they need a clinic. So under AB 1400, you know, we could look at an analysis of where they need care. How can we keep these patients closer to home? Why do you have to come all the way to Los Angeles? Now, granted, higher levels of care, sure, we're a tertiary center, whatever. But for just basic clinic care, you shouldn't have to drive 30 miles into Bakersfield, because a lot of times then you have to have reliable transportation. Anyway, So I'm sorry to really give you a broad generalization, Randy, on that, but I can't foresee like immediately, like we'll just take over these hospitals. I don't think that's going to happen. It'll be kind of like publicly funded, but then you will still have the current organizations will still be there to operate if they're in CalCare. So they'll be in, like I said in the beginning, opting out of CalCare would be like opting out of Medicare. Not very smart. But like I said, if they want to throw that temper tantrum, then they can starve for 2 years and then be the first ones ready to apply to get back in. So, and then from Fatima, why hasn't the governor moved on AB 1400, and what is the exact role of Healthy California for All? So the governor is our special friend. He is our special friend. He told us, and he told me directly in San Francisco at a convention when I was a delegate, that he is for single payer. He told the California Nurses Association he was for single payer, to the point where the California Nurses Association even gave him a big, big bus and took this bus up and down the state to campaign for him. So I'm just, this one, I won't give a speculative answer. I think that he's seeing which way we go. And it goes back to this thing, what I said in the beginning about Assemblymember Ashkara. When you challenge the status quo, it's a lonely place. You tend to make more enemies than friends when you challenge the status quo. It's uncomfortable, very uncomfortable, unlike what Ron DeSantis is trying to do in Florida, passing a stupid bill, or what they're trying to do, pass a stupid bill about, like, you can't talk about race if it makes people uncomfortable. What? Anyway, sorry, not going to talk about Florida. So, we still need the governor, right? I'm not going to throw out malicious attacks. I need him to sign this bill. I promise you, Governor Newsom, we will have the best date at In-N-Out with you and your family, all on me. When you sign AB 1400, all on me. We will go to In-N-Out and have the best double and lemon up and strawberry shakes, all that, all on Jeanna. When you sign AB 1400. But for right now, I think he's just trying to see. He's trying to see if we're going to put in the work. I think that's the best way I could say that and keep it PC. And then the exact role of Healthy California for All is, I think Maureen can go a little bit more into that. I'll let her go into that one.
Yeah. Fatima, I think, are you talking about the governor's commission? You can unmute.
Yeah, you can unmute. I'm sorry, I forgot you're in here. Sorry, yeah, you can unmute.
Yeah. And Healthy California for all. If it's the governor's commission, it's
yes, the governor's committee, the commission that he developed. He started it as a way to, I believe, to forego the transaction, to change from our system, the system currently, to the new system. So I haven't heard a real role from them right now. I mean, I know they're going to send, release some kind of data or letter next month, but I don't know. They haven't been brought up more lately, like in discussions for some reason.
Right. I think they've postponed the next meeting. I think Jeffrey probably knows about that, but they're merely advisory. That commission has no power. It has no power to legislate. It's just an advisory commission. We've had things like that before. The Assembly had a council on healthcare, which just spent a lot of time going over Healthcare 101. And the first few sessions of the Governor's Commission also just really did go Healthcare 101, and almost all the people attending the commission knew more than some of those commissioners, because they are political appointees, are not appointed for their expertise. There were some were, and a lot weren't. And as you know, the Governor's Commission had 12 members, and then Dr. Ghali, as the California Health and Human Services Chair, he was the convener. But of the 12 appointees, there were only 3 really identifiable as actual single payer supporters. That was, initially. So that was kind of gave us a clue. And there's an old saying from Will Rogers, who said that the only thing that slows progress more than Los Angeles traffic is a government commission. And I think you're right. It slows things down, but it certainly did give us a lot of information. And I highly recommend people go to the site and look at some of the reports that are there. There is some good information there, but they do not have the power to change anything or institute anything. They're just advisory. They're just there with information on the table and discussions on the table to be used or not. So
yeah. Thank you, Maureen.
Did that answer your question about it? About like I was assuming you meant what power do they have? Did that answer it?
Oh, she put yes, thank you in the chat.
Said yes, thank you.
Thank you. All right, going to Betty, and then we'll come back to the chat, and then we'll talk about a couple of other things that what's going on tomorrow.
I'm sorry. I just want to make I just want to make it clear that we're not taking over any facilities. We're not taking over hospitals. We're not taking those things over. If an organization that owns a private organization or association that owns privately a hospital doesn't want to do business in California anymore and they want to sell that asset off, they can. And then another person will come in and purchase that asset, that hospital, whatever that is. And they will get paid with global budgets from the CalCare fund. So yeah, there's no taking over of any healthcare. There's no of any doctors, facilities, hospitals, that kind of thing. They don't work for the government. They work for themselves. We just pay them from the Unified Trust Fund.
Yes, thank you, Betty, for clarifying that. So yeah, we are not going to run the healthcare. So that will probably be a Republican talking point, that it will be a government ran healthcare system. No. So, we, will not, CalCare you won't see a CalCare hospital like Kaiser has hospitals. You will not see that. We will just be, like I said, we're going to be a publicly funded single payer, but not a provider. Your providers will still exist. And then I'll just going through these questions. So from Randy, it says, so why is he, meaning Governor Newsom, pushing for managed care or, the CalAIM and other programs? So the governor, I think that he sees another path that is not AB 1400, that is a little bit more palatable to the moderate right side of the political spectrum. My answer, my comment to that, which has been the same for forever, is that if this was the path that they wanted to take to fix the broken healthcare system, they had more time, ample time, long before I came into the political scene, long before I could even vote, to do it. So the kind of a piecemeal step approach, the stair-step approach to solving this problem should have been taking place in the 90s. They tried to do it with ACA on the federal level with the Obamacare Act, and it got gutted, and it's nowhere near what it should have been. So now we are here to solve the problem. I am no longer going to treat a fever with just Tylenol. I'm going to the source of the fever. So if it's a virus, I'm going to treat the virus. If it is if it's a bacterial infection, I'm treating a bacterial infection. I'm not going to continue to treat the symptoms. Unfortunately, I think that some of the political leaders think that we can just continue to treat the symptoms, but that's because they don't provide care. When you provide care, you know that actually you spend more money sometimes if you do not diagnose the root cause. With AB 1400, we have diagnosed the root cause here. We need to provide access to care for everybody. Is it the sole answer to our broken healthcare system? No, but it is a hell of a lot better than whatever piecemeal approach anybody else is going to bring. Then after we address the access to care issue, then we start focusing on our preventative versus reactive healthcare system. And that is a big problem. Right now, we live in a reactive healthcare system, which is I'm sick. I need to get taken care of. We need to be taking care of ourselves as a whole body all the time. We are bodies, we are human. And so we need to work on more preventative medicine to keep people healthy, so that we can have a nice, sustainable healthcare system. Because yes, like healthcare, the healthcare system as it is now, because we are such a sickly society, is going to continue to grow exponentially. But could the cost of a single payer system go up as well? Just being honest again, I'm not here to sell you. Yes, if we continue to be the sickly society that we are, yes, we could have extreme healthcare costs on both sides. And that's why, like I said, AB 1400 is one key and the door that has multiple keys, like, you know, I forgot what movie it was now that had the keys in the door. Anyway, so you've got to turn these keys, but we need to start putting the keys in the door. Every time we try to put this single payer key in the door, some politician wants to knock it out, and we cannot allow that to happen anymore. Let me put the key in the door. I have other keys to go find. I'm on a quest here. I'm a hobbit. I'm on a quest. I have to go find my other keys. I have one key, and I'm like, so let me go put this key in the door, please. Thank you. Instead, I have like Gandalf at the door. You shall not pass, is what's going on in politics right now. Anyway, sorry, going to the next question. And then from Robert Kopler, we have allies in other states that are full support of AB 1400 and hoping we pass AB 1400 and ACA 11. Yes, and you want to know why? Because California is the flipping Saskatchewan. So if you know, people in New Mexico see what we're doing and they know that we get it in California, then that gives them momentum to go and do it in New Mexico. And I picked New Mexico because I just thought of a random state that, you know, could probably really benefit from this. So, you know, that is what needs to happen. We need to give the whole country momentum. So that then they can go drive and say, okay, well, look what California did. They will have a model at that point to follow. Right now, there's no model. The questions that you guys are asking now, it has to be speculation because we have not done a single payer here in California. We haven't done a single payer here in the United States. Are there single payers nationally, or excuse me, globally? Yes. But because of our complex healthcare system here, I can't give you the exact answer. Someone asked me about workers' comp. I can't give you the exact answer on workers' comp, but I can tell you that workers' comp will have their work cut out for them because then they would only have to provide the financial compensation side. Your healthcare could already be taken care of under CalCare. So then they would just have to provide you the remuneration benefit of making sure you're paid while you're off work. So truthfully, if we're going to flip it, since the Republicans are going to come at me about cost, let me talk about cost. Sorry, I got a little neck snappy there. But anyway, so if we want to talk about that, so for a workers' comp company that is paying out your healthcare benefit and paying you a check because you're on a worker's injury and the company having to pay that work comp premium, if the insurance company only has to pay now half of that, they're only covering now the payment part, making sure you get paid while you're off work recovering, then maybe, don't get me wrong, we're a capitalist country, maybe they can then take their premiums down, which would then cost the employer less. Ooh, thought. And then from Randy Hicks, can we use the new study to influence the commission? Oh, how I wish. I can't say that the new study would influence the commission, but like I said, the commission was an exploratory thing. It was something for the governor to basically, like Maureen said, slow down progress, slow down momentum. Obviously, nothing's slowing down this train right now. So I don't think, I'm not too worried about influencing the commission anymore. You know, they're barely meeting right now anyway. And I get it because Dr. Ghali is the director of public health. And I know with COVID, he's busy, but I'm not too worried about the commission right now. I'm just looking at the votes. I'm just calculating on the votes, who's influencing those votes, what's making it, what opposition are we facing, and can we flip that opposition? Can I tell you something? Can I convince these senators, these assembly people to change their vote based on, me countering whatever they heard? So that's what I'm focused on now. The commission, thank you for your service. Healthy California Commission, we appreciate all your work. Thank you for your research. Thank you for your time. But we're going to move on and go to the votes. And then Maureen said, this is the 7th attempt since 1988 at single payer reform, or 1998, oh my God, in single payer reform in California. Isn't that sad? And that's so sad. Like I said, we keep trying to put the key in the door and we keep getting told you shall not pass. So sad.
And I have to say the very first attempt in 1998 was Senator Diane Watson and Senator Barbara Lee. So two Black women, 1998, two California senators were the first ones to push reform in the state of California 24 years ago.
See, crazy. 24 years ago, that put me at like, you know, I was like, what, 10 years old, 10 when we started trying
that to Dr. Weber, because they are good role models.
Yeah.
Dr. Weber,
AB49, AB79. If you are in AD79, please mention that and tell that Black woman to lead, please. And so nicely. And so then we are at 6:01, and I was trying to keep office hours at just for an hour. Why? Because we have some super exciting stuff coming up tomorrow. And I'm going to hopefully share my screen because I want you guys to see the flyer. Oh my gosh, and Zoom is now being stupid. So here we are. Nope, come on, Zoom. You guys wouldn't be surprised. Me and Paul were on here at 4:30 practicing, and we had it flawless with this commercial, and it still didn't work. Okay, so here we are. We have our Fourth Monday speaker series tomorrow with Wendell Potter. If anybody knows the atrocities that go on the insurance side more than me, it's him. I know I'm in a unique space because I've worked on that side too and can provide that perspective, but he's providing it at that VP level. So his position was very much so higher than mine. And he was one of those people who I would be cussing at the phone because they feel like they were out of touch. But as the flyer said, he saw the light, and I've actually got to talk to Mr. Potter in a couple of different spaces. And he knows the strategy. He knows what's going to come at us. He knows how they're going to move. He knows how they think. So this is a very good speaker series to join us tomorrow. We're going to drop the links here in the chat, or you can go to the Healthcare for All Los Angeles Facebook page, and it should be like the second or third post. And you can join, because like I said, it's a very good perspective for how these insurance companies move. And that's when I say, when you are profit driven instead of care driven, it creates a whole nother game. So come join us tomorrow at 7:30 for our speaker series. But before that, CNA is having a virtual rally to talk about our next steps as we're getting ready to head to the assembly floor in the next week. So if you want to join the CNA virtual rally, we're going to drop that link in the chat as well so that you can register. I'm pretty sure they're going to have some really good info and insights and plan and strategizing. But the biggest thing, guys, every assembly district, 1 through 80, needs a phone call from a constituent. I know here in Los Angeles, a lot of us live in the same districts, but, you know, I'm encouraging the constituents of every district to call. Even if your person is already on board, just call and give them a thanks. And we got your back, and tell them that, you know, we're here for you. You know, you can go live from the assembly floor if you want, we'll watch. And let them know that, you know, thank you so much. But if you have if you live in the Inland Empire, especially, you know, ask them, what are your concerns, you know, and another good question, would you be interested in hearing, you know, how a different opinion or a different thought process? You know, those are the types of things, those are the types of ways you can now combat opposition. Is that, are you open to it? You know, come from that standpoint. You know, don't waste your precious oxygen if they're not even going to be open. Are you open to hearing a different viewpoint that could possibly make you change your vote? And, you know, if they are, great. You know, Maureen and Healthcare for All Los Angeles, we're all kind of at the ready to answer these questions. You can email us, anything like that. If you get one of those and need a quick answer, we check that, we see that email multiple times a day. So I really encourage, you know, that you guys to do that as well. But like I said, we really, the key is just getting, like, the Ash and all the assembly members are whipping votes as we speak. I'm sure right now they're on the phone and meeting and doing things, but we need to also try to whip these votes as constituents as well. And then Jeffrey, I see you put your hand up.
Yeah, I was just going to serve as a reminder years ago when the ACA was first going forward, the legislator realized the lack of in the San Bernardino area. So they put money forward to make the Riverside being a medical school, because they have found in the past that where you, in a sense, go to school is likely where you're going to be practicing. Just a quick heads up on that. And I had some other thought, but I've forgotten it for now, typically. But being in Sacramento, I also was here when, and they testified for the private hospital that's up at Lake Tahoe, Truckee, to get them funding. And they're one of the few that had that issue. And because somebody died, somebody donated to make sure that there was a hospital up there in the Truckee area, because like many of the, should we say, rural areas, there's not a hospital. I constantly hear about through telehealth that people coming down from Crescent City and from Eureka and everything else, because UC Davis is the place that the specialists are at.
Yeah, and that's a big issue. Like I said, access to care in these rural areas is very problematic. And then especially with COVID going on right now, good luck getting into my place of business as a transfer, because, you know, we're inundated with higher level of care transfers from inland to rural areas. People need to get in to get care because they can't get it in their area. So, you know, thank you, Jeffrey, for helping with that, getting care in these rural areas. It's much so needed. And so I think that's all the questions. We've got the links in the chat. So I hope to see you guys tomorrow on the CNA virtual rally, and then meeting us again tomorrow evening at 7:30 to hear from Wendell Potter, who will probably for sure be talking about AB 1400 as well. And I enjoy you guys like I do all the time. I thank you guys so much for joining us, and continue to take care of yourselves. Stay safe out there. Omicron is still, while they think the peak may have already occurred, we're still seeing thousands and thousands of cases every single day. Hospitalizations have more than, I don't even want to know the amount, have increased since the beginning of January. So, you know, continue to keep yourself safe as much as possible. Thank you, everyone. And we will see you again, not in this space, but probably with the speaker series tomorrow. Bye, everyone.